Welcome to RadClerk Demos. Today we have Claudia Kassid, and she's going to take us through this musculoskeletal radiograph. Claudia, take it away.
So we have a 28-year-old patient following trauma. We begin by verifying the image, so making sure that we have the correct patient, using at least two identifiers, name, date of birth, or MRN. And we also want to confirm that we're reviewing the correct and most recent exam. And here we have October 2nd, 2018.
That's great, and things get busy in the hospital, so grounding your approach to a radiograph by first just doing a sanity check. Am I looking at the right patient, and am I looking at the right date for the study and not an older study? That's a great way to start. No matter how busy it gets, if you're anchored like that, then you're going to start off on the right foot. Tell us what views we have here and how that compares to the standard view you would get if you ordered a single view of the pelvis.
So here we have an outlet view and an inlet view, which are very important and gives you visualizations to assess fractures. And a standard view would be an AP view, which is anterior posterior, where you have
Mhm.
the X-ray beam shooting from the top, going anteriorly, and then detecting from the back posteriorly.
Great. So anteroposterior just means that X-rays enter anteriorly on the patient and exit posteriorly. So, and that's the standard view. But we have this inlet and outlet view. What's the benefit of getting multiple projections on a single piece of anatomy like the pelvis here? How does that help us?
Well, the pelvis is a three-dimensional structure, so getting multiple views kind of helps with sensitivity to fractures, to assessing different
Awesome.
fractures.
Yeah, so much more than any other part of the body with MSK, the pelvis really is far more three-dimensional, so that's perfect. Now, we often start with adequacy of technique, and what acronym do you use to assess adequacy of technique?
RIPE-F acronym, which stands for rotation, inspiration, projection, exposure, field of view.
Great, and obviously inspiration not relevant to musculoskeletal, but if you want to look into the details of that and you're watching this demo, you can go to radclerk.com/templates. We'll put the link in the comments below, and you can read a little bit more about that search pattern as it relates to MSK. Now, let's just say this technique is adequate for this study. Moving on to pathology, what acronym do you use in general for your musculoskeletal radiographs?
BJS, which stands for bones, joints, and soft tissue.
Awesome. Great. So you'll use that here. And, the first part of the bones acronym involves looking for skeletal maturity. And obviously, as a skeletally mature patient, there aren't open growth plates on this particular pelvis. There's certainly no ossification centers. And then there's also bone mineralization. And we're not seeing extensive trabeculation or lucencies. So bone mineralization is fine. Let's move past that into assessing the bones for fracture. Tell us about the search pattern that you use to get really high sensitivity to fractures on the pelvis.
So when looking at the pelvic, we're assessing for any step-off fractures, avulsion fractures, or any transverse or oblique fractures. So starting with the main pelvic ring.
Okay, great. Here we have the main pelvic ring. And what do you think about this main pelvic ring? Is it normal or abnormal?
It is abnormal. There is a slight step off right here in the superior pubic ramus.
Nice. So you're seeing a fracture and you're coming down, following along with your eye and seeing a little fracture here. There's a little irregular right here, but that's within normal. It's likely just normal anatomy. If you're worried it's a fracture, then what would you get to assess and really increase your sensitivity for pelvic fractures? What would you order?
You would order a CT scan of the pelvis without contrast.
Okay, great. Yeah, you don't need contrast here because we're not trying to elucidate the vessels. Obviously, if it was a really high velocity trauma, like a car accident at 80 miles an hour, then you might be worried about contrast extravasation, the person bleeding out, and maybe then you would advance to a CT pelvis with contrast. So routinely, CT pelvis without contrast is how you'd kind of escalate to investigate further. And so far, we definitely have this one irregular right here, and then maybe this could be normal variation. It could be a fracture line. We're not 100% sure just yet. So that's the main pelvic ring. What's your next contour that you're going to be looking at?
The next contour that I would be assessing is the obturator foramina bilaterally.
Okay, what do you think about the obturator foramina here?
So here we would have to switch to the outlet view to get a better visualization of it.
Yeah, I agree. The inlet view is really causing the obturator foramina on this projection to look foreshortened. So let's move to the outlet view, just as you suggested. Okay, so here we have the outlet view. I agree that the obturator foramina look much better here. What do you think about the right obturator foramen on this view, the contour?
The right obturator foramen looks normal within normal limits.
Okay, it's normal. And what about the contour on the left obturator foramen here?
So on the left portion, there is a contour abnormality on the left side, suspicious for a fracture.
Okay, great. And now this fracture, we talked about a fracture up here, which actually is almost invisible on the outlet projection. That was the superior pubic ramus fracture that we saw right here. Now, if this is a fracture, then what body part does it go through?
This would be the left inferior pubic ramen.
Awesome, perfect. Left inferior pubic ramus, that would be a great way to describe it. So looks like we have two fractures so far. When you have a fracture in a ring, what does that tell you about the presence or absence of additional fractures in a ring?
There could be other hidden fractures, for example, like an anterior or posterior acetabulum fracture.
Yeah, I mean, those are just specific examples of fractures, but in general, when you snap a ring in one place, it's likely to snap in another place. And so, yeah, we see one fracture right here, but we might be suspicious about whether there's some other radiographically occult fracture somewhere else along this particular ring, and similarly for this fracture right here. Okay, great. All right, so you finished with the obturator foramina. What do you look for next in terms of your contour?
We look at the lower portion, so including the ischial tuberosity bilaterally.
Great. And what muscle attaches onto the ischial tuberosities?
The hamstring muscles.
Awesome. So avulsion fractures involving the hamstring, you're going to see them, little arcs of bone at the ischial tuberosities. What's your next contour?
Next contour will be the iliac crest.
Okay, out here, and after the iliac crest, what do you look for next?
We're looking for the anterior superior and anterior inferior iliac spine.
Nice, great. So we've looked at the iliac crest and the anterior superior and anterior inferior iliac spines. Obviously, there's muscle attachments to each of these. By the way, what muscle attaches to the iliac crest?
The gluteal muscles.
Great, yeah, the gluteus medius and the gluteus maximus. Now, there are additional muscles that attach to the anterior superior and anterior inferior iliac spines. A year from now, you're not going to have that memorized. How are you going to find that out?
I would look it up on Google Images.
Yeah, so Google Images pulls up some of the really nice diagrams that show you exactly where these muscles attach. So it's a good place to go, especially if you've already studied it once. You know what are the reliable diagrams to go for. Okay, that's a great overview of searching for pelvic fractures. And of course, there's bones, joints, and soft tissues. We haven't talked about joints and soft tissues, but that'll be for another demo. Claudia, great job on the rotation and best wishes for your next steps.
Thank you.